Hi, everyone. Welcome to a special Wednesday edition of the Division of Epidemiology and Community Health seminar series. My name is Katie Berry, and I'm a new assistant professor in the division. As you may have noticed, our usual seminar series chair, Rachel, couldn't be here today, so I will be filling in. However, being as cool as Rachel Whittam happens to be one of my greatest aspirations in life, so I will try to do my very best at running the show. I'm delighted to welcome Dr. Alfredo Moravia as today's speaker. Dr. Moravia has been serving as the editor-in-chief of the American Journal of Public Health since 2015. He also currently holds positions as a professor of epidemiology at the Barry Commoner Center for Health and the Environment at Queens College, City University of New York, as well as a position as a professor of clinical epidemiology in the Department of Epidemiology at the Columbia Mailman School of Public Health. As the principal investigator of the ongoing NIOSH-funded World Trade Center Heart Cohort Study, Dr. Moravia leads research examining the long-term effects of the September 11, 2001 attack on the heart health of first responders. Additionally, his expertise as a historian lies in the history of scientific methods employed to study populations, particularly focusing on methodologies where counts and statistics play a pivotal role in identifying causes and implementing effective interventions. Recently, Dr. Moravia authored The Public Health Approach, Population Thinking from the Black Death to COVID-19, which was published by Johns Hopkins University Press in October 2023. This book offers insights into the evolution of population-based approaches to public health, spanning from historical pandemics to contemporary global health crises like COVID-19. I'll admit that I haven't had the pleasure of reading Dr. Moravia's book yet, but after recently reading a glowing review written by our own Henry Blackburn, it's now been bumped up to the top of my reading list. Dr. Moravia, thank you so much for being here. And I would like to present to you the coveted Epidemiology and Community Health Seminar Series glass as a token of our appreciation.
Thank you. I should. Okay, thank you very much, Kathy, for this introduction. I'm very excited to be here because, again, it's my first time that I come to this school, and also that I visit Minnesota, and I will visit, and I'm just for the record, I'm at 43 states. So I have the intention to go to 49 by the end of the year. Anyway, it's my great pleasure. I also want to thank for the hospitality and the invitation, Henry and Stacy. And I also noticed that Matteo, one of our student think tank member of the American Journal of Public Health. All right, so I would like to go for 45 minutes and then have a conversation with you. I mean, it's not about telling you why you should vote for one candidate or the other. I mean, in Minnesota, there's no discussion, but I just want to discuss with you, how deep the problems for public health are. And so that's a paper and an editorial and a talk that I developed after I read something from the ACLU. But before I go, I want to say.
I don't know if your mic is on. Okay, is there a way to turn it up a little bit? I can't hear it.
I can put it up over
You? Okay, perfect. We'll turn it up at the source. Thank you. Go ahead. Sorry about that.
So Katie said I'm from the Barry Commoner Center. So who's Barry Commoner? And I don't know if any of you knows him, but that's why I wanted to show you this. Barry Commoner was a very famous biologist and ecologist. He once was, like Ansel Keys, he had the Time cover of magazine, and he ran for president in 1980 against Ronald Reagan. And he had actually a vice president on the ticket whose name was Harris. And it took 45 years to have another, or maybe a little bit less. But LaDonna Harris was a Comanche from Oklahoma. And I was in Oklahoma last week and I showed them that. And they knew her and they didn't know who Barry Cummings was. But that's just a little reminder of, or explanation from the center where I work at Queens College. So this talk and an editorial that went with it came after I read this article from the American Civil Liberties Union, ACLU, which I found really absolutely striking because the ACLU is not a partisan organization. They actually defended the former president, but they said we must believe Trump when he reveals his authoritarian plans for a second term and take this threat seriously. He has made clear he intends to deploy the military to crush protests, activate state national guards to deport millions of immigrants, build on his legacy of gutting reproductive freedom by implementing a nationwide abortion ban, create a police state in which anyone who he views as an enemy is surveilled, and our law enforcement are further empowered to use lethal force and undermine the integrity of our election. I said, but the next paragraph was even worse because they say fight back. No, fight on. I mean, before it happens. But anyway, what this told me is that it was just against everything that makes a public health efficient. For public health to be efficient, it needs to be science-based. And in my book, I have plenty of examples. When it's not based on science, it fails. It needs to include everyone, needs to be just, needs to be professional, because you cannot improvise a public health approach or population thinking. It's just something you need to learn, and it needs to be democratic and participative, and maybe that's where we have the more work to do. So I'd like to see each of those points and to compare what happens when actually they are followed or they are neglected. So science-based. There's a lot we can criticize about the COVID-19 response. We did in the journal. It was really, it hurt, the poorest and the most disadvantaged population much more than the other. And we wrote in the journal, we're not in this altogether. And the other great limitation that we developed a lot in the journal, it was the lack of really health monitoring system. We didn't know until today, how many people had COVID and were asymptomatic. We had no population-based health monitoring like in Spain or in the UK. So those were huge criticisms. But on the other hand, the vaccination campaigns were a historical success. I mean, nobody in 2019 would have predicted that if there were a vaccine mandate, if you take the population age 65 plus, which were the population most at risk, 95% of the US population has been vaccinated, fully vaccinated. When nobody in 2019 would have predicted 40%, 50 on the base of our historical record, 95%. And this is for the population 18 years old or more, and every state vaccinated more than 50% of its population. But where we really see the power of the public health intervention is when you look at the 65 plus. The state with the lowest vaccination rate is Arkansas with 83%. That's, that means that for every state, it was clear, first of all, that the vaccine worked. And second, that the 65 plus were at higher risk. And no state took the risk of having a huge killing in this population. The challenge was clear, the instrument was clear, and the job was done. And this would never have been done without the role of CDC. Background role, but how CDC got the vaccine in red states with low public health infrastructure, it's really something remarkable. It's programmed with pharmacies, etc. So this campaign has been a tremendous success for public health. And when we look at Minnesota, you see the same thing. You have 96% of vaccination in the full vaccination, complete vaccination, 92.7%, and of the people in that age. In the younger population, it's a different story, but the rates of vaccination are very high. And it's very important to see, when you look at Minnesota, there are parts that were less vaccinated than others. I don't know those parts, but I was once in Texas, not so long ago, and I saw, Texas was 99.9%, vaccinated in the 65 plus. But look, there is this county. Why? So you imagine this county. You imagine they're all behind their truck with their guns and waiting for the people to come and watch out, because if you. So I said, okay, let's go to this county. This is King County. And I entered it in Google, and so this is King County. When you get there, with your vaccine and your cold chain, and the GPS says you've reached your destination, you may continue because there's no. So the reason why not more people were vaccinated are not that straightforward. So there may be many reasons. I was in Alaska. There is behind the polar circle, etc. There are places in which it was not necessarily people didn't want it, but there could be other explanations. And the other side of this is that the side effects, and we knew this very early, were extremely low. And there is this recent report from national academies that shows that the side effects were almost null. And I won't go through this whole table, but when we go look at myocardial infarction, ischemic stroke, there is nothing that seems to be causal when we talk about the mRNA vaccines. So, and the deaths were extremely small. So a huge, and the chance also for public health to show that how well it can work. But in order to succeed like that, you needed public health expertise. There is no way that the vaccine could go from the warehouses of the pharmaceutical industry to the arms of people. Only with the generals who were running the project at the White House in 2020. You need the refrigeration, you need to train people, you need to identify those who have, everything but all this needs to be supported by some professional expertise. And the collaboration with the private sector, which is more important in some states than other. That's why I wrote this editorial. Public health expertise cannot be improvised. And this is something we need to take in consideration when we think of who's coming at HHS or at CDC. And we can count the number of lives that were saved, the number of hospitalization, which avoided, a greater mess in our healthcare system, the number of deaths that were saved. So the vaccination campaign, and this was all science-based, but we know that those who deny the role of science represent a danger. Oh, it's still in another language, which is actually anyway. But we published this year this very important paper by Wolf and colleague about excess death. And you know, excess death is really the measure to assess the impact of COVID-19, because everything that's COVID-19 specific has problems. Because not everybody was tested, there were differences across state. But globally, if you take the full excess death compared to another time period and compare states, you have an idea of the impact. And so what this paper showed is that there are different phases of the pandemic. As you know, there was the beginning when we don't know really what was going on. And here, democratic states, which are in the black bars here, and more. You know, there was New York, etc. There were all these large cities who had lots of death. But then, as soon as we start to have means of individual protection, this is the second set of bar, or we have the vaccine, the first set of bar, the excess death is much larger in states which had a Republican governor compared to a Democratic governor. And so the excess death in those states was really extremely important. And actually, I'll show you later, most of the death that occurred in the country after the vaccine was available was among Republican. And the 10 states with the highest excess death rate were West Virginia, New Mexico, Mississippi, South Carolina, Wyoming, Louisiana, Arizona, Kentucky, Arkansas, and Alabama. Minnesota is not there, don't worry. And when you look at the map, this is during phase 2, the pre-vaccine period. The darker is where you have more excess deaths, and this is during the vaccine period. And actually, Texas did pretty well. So, you know, I mean, this is when you refuse or don't recognize the role of science, you actually are a danger for public health. And those deaths were mostly preventable. So because there was a denial of the role of science, of the importance of the vaccine, of its protective effect, even though, you know, it was those states, they really actually knew that it worked. But the language, the political language and the division were created, you know, for political purposes and not for, for public health reasons. The second very important element, you know, for public health to be effective is that public health needs to include everyone. I mean, a virus doesn't know whether you're Republican or Democrat. We need whether you're documented, non-documented. It's in order to be effective, it needs to be to include everyone. Every ideology that excludes any subgroup of the population is incompatible with public health. Because the only thing you can do with the group you exclude is to destroy it. Otherwise, it will represent always a threat for the rest of the population. That's why extreme right ideologies, supremacist ideology are really incompatible with public health. But I want to show you this study, which it was also about Republicans and Democrats, but it's a real cohort study. And in this setting, to understand what I mean, it was really based on individual follow-up. It was the excess death rate, which is the right measure, Republican and Democrat, and the Republicans and Democrats were identified in electoral registries. So they were individually identified, and then they were followed in mortality registry. So it's a real cohort, and in Ohio and in Florida. And you see, it's during the 2021 year when the vaccine was introduced, and most of the cases occurred in non-vaccinated, most of the deaths in non-vaccinated. And so the idea of these economists was that if this is true, then since Republicans tend to be less vaccinated than Democrats, we should see more excess mortality in Republicans. And indeed, they took the excess mortality compared to 2019. So this is 2018, and you see that in those counties of Ohio and Florida, there's no difference of mortality. There's no excess mortality in 2018 and compared to 2019. When you go into 2020, we start to see a difference. You know, the red are the Republicans, but once the vaccine is introduced, you have a 20 point, percentage point difference here between Republicans and Democrats. And this is just the difference that is plotted. And so this study had a very, two extremely important observation. Let me explain to you what's here. You have here the proportion of vaccinated in counties. So this is in 2021. This county had 20% vaccinated. This one has 60%. And this is the excess mortality in 2020. So in counties where the people tended to protect themselves less, and then ended up less vaccinated, you see that both Democrats and Republicans die more. But when you go to 2021 and the population gets vaccinated, when at least 50% of the population is vaccinated, Republicans are protected. You see, and so it matters whether you are in a county with a high proportion of vaccinated in one sense or the other. Before that, it killed other people and then it protected. So this is about Republicans and Democrats and this is why I wrote this article, because I was showing this and people were saying, it kills Republicans, so what's the problem? Where's the problem? No, you cannot think like that. It's not a public health approach. It matters whether Republicans die more. Yes, we should care about Republicans dying more than Democrats because COVID, public health includes everyone, Republicans, undocumented immigrants, the poor, everyone. That's a very important principle of public health. So as soon as you start excluding people, then you become a danger for public health. And we published about the consequences of it was a rhetoric because actually it was not a real threat against immigrants. This public rule law that if they were applying for benefits like Medicaid or SNAP or other types, whether for care or for food, etc., they would be denied a green card. And so it was in practically, legally, it was not concerning a lot of immigrants for different reasons, but only the threat had implications on the behavior of immigrants. And we know that any measure that make it harder for immigrants to obtain visa residency have visible implication. We published this in the journal. That's interesting when I bring my. You hear me well now in the back? It's okay. So when they changed because of the public health, they introduced the public health child rule, which was again a threat. It's not been really introduced. And in New York, they followed the weight of newborns, and you see between people who are citizens and non-citizens. So there were no difference between the introduction before the threats of the public charge rule, and then once they were saying that those immigrants, they may not have access to citizenship or even residence, then the weight of their children started to go down because they were not consulting, they were not using healthcare. They were afraid that this would have consequences. And this is for New York City, and this is outside of New York City, where the effect was even worse. And so when this immigration, if the future administration really deports millions of people, you can imagine the type of consequences this is going to be for those who try to stay here and for those who will be expelled. So excluding people as the Republican candidate, threatens to do, is a danger for public health. The other key principle of public health, without which it is not effective, is the question of justice. If you're unjust, you just cannot have an effective public health approach that will improve the health of everybody. And there are many forms of injustice, and you know them very well: racism, disablism, patriarchism. And anti-feminism is a very important one, and probably one in which we've done the most and the greatest progress. And so one of the changes that occurs after the 60s was the right to abortion. And you may remember, no, you don't, because you look too young, but maybe Henry and I. But this is not, Lyndon Johnson is not the issue. It's the High Court rules abortion legal for first 3 months. So in 1973, abortion was made legal at the federal state. And so what happens after that? It became extremely an important mean for managing their life for women in the United States. What you see here in gray is the cumulative number of first abortion in U.S. women in 2014. So it accumulates faster than what you see here because those are 4 years, etc. But what you see that is that in their life, about 25% of US women have a first abortion, not even talking about. So 25%, which is extremely high. And it means that it's part of everybody's life and everybody's family. And when you look at subgroups and non-Hispanic Black women, we go in 2008 up to 40% of women that have a first abortion in their lifetime, which is extremely high and is extremely understandable. So the trends were going down from more recently and before the Supreme Court's decision to cancel, the Roe versus Wade decision and the federal right to abortion. And since then, and it's been 2 years, we've seen terrible consequences already. We call it over the precipice into the post-war world. But this is how already, the map of the US looks. In red, you have states that have full ban, severely legally restricted and inaccessible. In purple here, you have those with moderately and those with least reduction of the right are in blue. So the landscape has already completely changed, and it has huge implications for a lot of women. For example, this is in Texas. It's the distance it takes to get to a facility where you can get an abortion, and when you look, this is more than the people in this area have to travel more than 440 miles to find a place where they can get an abortion. And this one, about 300, etc. So this means it takes time. You need to find a place. You have to have the money. You have to, you delay the moment of the abortion, etc. This was in Ohio that we published about the impact of the transient ban on abortion. You see that immediately when the ban was applied, there was a reduction in number of abortion. And as soon as it was the decision of their court was blocked, the number of abortion would have been. So we know there will be tremendous consequences, and these are cases you've heard about. Some women that have been, refused emergency care because the doctors are threatened that if they do an abortion in conditions that are not legal, that they're going to have problems themselves. So if you're unjust, you're a danger for public health, and this is what we are frightened of. Now, another very important aspect is the leadership. If we don't have people that are trained to be public health professionals, they just cannot lead departments like HHS or CDC because they just don't understand the principle. And I want to give you an example that shows the difference between being a population thinker and being I would say a normal person, but a person who hasn't been trained, because you never discover population thinking spontaneously. Something either you've discovered in data, which occurred in 17th century, or you need to be trained. Otherwise, the switch between individual and population thinking never occurs. It never occurred in the history of medicine for 4,000 years. It needs to be discovered or taught. And so here's the case of Hank Aaron. So I suppose you know who Hank Aaron is, but you may not know that Cassius Clay or Muhammad Ali said he was the only man he idolized more than himself. Okay. Not even Malcolm X, not even, that was the man. So as soon as the vaccine became available in January 21, Hank went to Morehouse to get a vaccine, and he did it publicly. He really wanted to convince the community. And it happens that 2 weeks later, I just come back to here, but the Atlanta Braves, where the Braves had moved, said that Aaron passed away peacefully in his sleep. Okay, so that's he died 2 weeks after having had the vaccine. So that journal that I'm showing is the Children's Health Defense Team, and who is the chairman of the Children's Health Defense Team? All right. So, I mean, let's look at what that journal said. They said, he got the vaccine, he died after, so the vaccine killed him. All right? And in some ways, this is how we are selected naturally to react. When you put your hand in the fire and it burns, you take it up immediately and you do, there's a causal relationship. But when events are probabilistic, it doesn't work. So you need to understand how to think and to infer causality in the presence of events that are not, always connected, like putting one hand in fire or escaping when you see a danger. So I just want, and I'm sorry because I know you're epidemiologists, but I just, for the sake of my presentation, want to remind, to explain what's the reasoning when you have the case of Hank Aaron. when you think let's move to tobacco and lung cancer, we're comfortable there, all right. But so if you only based your judgment on the impact of tobacco on lung cancer based on the people you know, you cannot even imagine that tobacco causes lung cancer because only 10% of the heavy smokers are going to have lung cancer. Most of the heavy smokers we know don't have lung cancer. And that's what the judges, before they introduced the action of those Hills criteria. Oh, I smoke, my neighbor smoked, we don't have lung cancer, and we are quite old. But yeah, 90% of these heavy smokers. Okay, smoking has other effects. Henry will tell you, the cardiovascular effects are much larger. But anyway, this is the reasoning. In order to know that tobacco causes lung cancer, you have to compare. You have to compare two groups, two populations. You have to bring the question at a population level, not at an individual level. Who do I know? But as a population, what is the experience of smokers compared to non-smokers? And then you find a 20-fold difference, and then you can start thinking that there is a causal relationship. So that's what we need to do with Hank Aaron. And that's what the leader of HHS or CDC should be able to think of when the situation. You have to compare what was the probability that Hank Aaron would have died of heart attack, because that's probably what happened. He died during the night, quietly, his heart stopped. What was the probability this could have happened independently of the vaccine? And on the other side, what's the probability the vaccine would have killed him? And given his age, and these are things we can compute. There were already 11 million people of 65 plus. He was 86, but 65 plus who had been vaccinated. From Framingham, we know that the rate of cardiovascular event in this age group is 0.04 per week. You apply this to 11 million people. We were expecting 5,000 deaths like that, independently of the vaccine per week, so 15,000. Hank Aaron was at high risk of dying that week anyway, and this is what the data tell us. And if you look at the vaccine, then it goes exactly in the direction. Vaccine is extremely protective. And we have this this National Academy's report now that says that for the 2 mRNA vaccine, there's no causal relationship with myocardial infarct or ischemic. So that's how a population thinker, a person trained like you and me, can think about the case and conclude that it was not related to the vaccine. But if it's someone like Robert Kennedy, who is in that position, is going to be a disaster because they just cannot do this type of thing. And believe me, I know a lot about that. There's no trace of population thinking before the 17th century. No one even suspected it before there were data in London in the 17th century. So, but since then, with training, you can be in public health, epidemiology, demography, statistics, Darwinian biology, etc. All those disciplines, they are based on population. So the last thing I want to tell you before we open for the discussion is probably the element which is essential for public health and on which we have the most to work. And I think we are going in the right direction. One of the great lesson also from the pandemic is that when we don't include communities actively in the research or in the policy making, we fail because we don't develop trust and we probably don't do the right thing either. So being participative in research and policies is really important. And we need to develop a bottom-up epidemiology and public health. Now we're far too much top-down. And I'm going to use a very simple example, not COVID related, but striking. And this was when the mayor of New York, Mike Bloomberg, who has been very supporting for public health. I mean, there's no doubt he knows the importance of public health. He's been funding the New York Department of Health. And as you know, Hopkins has his name, it's the Bloomberg School of Public Health. And so they decided to do something that made a lot of sense. You know, they would ban those huge cups, you know, to buy soda. I mean, you know, 32 ounces, 1 liter. And so that was a mean to prevent, you know, the growing obesity epidemic in Harlem, in the Bronx, etc. It made total sense to do it. But they just went with the ban, you know. They decided from now on it's going to be, you know, bodegas, etc., cannot sell this type of. And the reaction was extremely negative. You know, all the community organizations start to fight it. And then finally there was a judge that decided that it could not be implemented because it had too many problems and loopholes. And so, you know, some journalists went to talk to Ben Gildas, who was the president of the NAACP, and said, oh, why do you do that? I mean, this is for your community. This is for the kids that, you know, are getting. He said, yeah, I mean, we're totally in favor, but come and talk to us, you know? And I love this, you know, come and talk to us and we'll do it right. And he mentions, you know, the bodegas, we need to convince them, they're going to have a loss of income. There's publicity from Coke, there is, you know, the kids who think, you know, why us and not the white kids in the rest of New York because they don't care about, you know, there's a lot of issues that you need to solve in order to be effective. And I'm sure they had taken the time and had discussed with the community and done what needed to be done, we would not have this terrible situation. But my last word, and I will stop after that because I want to have time for conversation, is that people too often think that the bottom-up epidemiology, because, you know, intersectionality, etc., there are methods that actively involve the participants in our studies, but all these, the community engagement doesn't occur spontaneously. You need to invest in it. They need resources, they need training. You know, in labor unions, they have leaders because they train them. You know, it's a whole process. Because otherwise, you have professionals who go to the community and we are trained. But how do you want leaders in the community to appear spontaneously? And where and with which resources? So we need really to create the infrastructure for the other side of public health, which is the bottom up. And we, I just want to go to, there is a big effort going in this direction. And we've published a couple of supplements recently. Where are they? That shows that NIH are here. Yeah, they're here. The federal agencies have developed this idea of community engagement. A lot of work is being done. It's really at the early stage, but I think AJPH has done a lot to really find in this work the most important studies and actions and intervention and publish them. This was Radex Up, it was for testing, and we have another, and we have two supplements with them, and another which is for vaccine. So, okay, I want to stop here and just to say that I'm really, I felt extremely concerned when, what are you doing? Sometimes, yeah, okay. And when I read this ACLU, because really it touches on each of our fundamental principles. And this is what's at stake for in this election. Thank you.
Thank you, Dr. Marabia. All right, who has questions?
Thank you for an excellent analysis of this. There has been discussion about, are we prepared for the next pandemic? And, you know, this one is over, it's 4 years ago, there are other issues. Do you think public health is adequately preparing for the next one? Because it will happen.
Yeah, and so I'm absolutely convinced that the answer is no. I mean, absolutely. And there are many reasons for that, but one of the key failure of public health during this pandemic was the absence of health monitoring system. We could not track the evolution of the epidemic in the country. And we needed to have an infrastructure for that. Of course, we had, you know, a system based on faxes, etc., who completely failed down. But even when they recuperate for that, we were, as you know, Politico said, flying blind because we had no dashboard of what's going on in the book. In order to do that, there is only, and we really published on all the experience that have been the large ones in the world. You need to have a systematic, you know, random sampling of the population that goes on during the whole pandemic, and that tells you where it is and what's the proportion of asymptomatic cases, because they go in the denominator of your case fatality rate. Without this, you just have no idea what's going on. So I was very hopeful with the previous CDC director, Walensky, because she had a plan. And it costed a lot of money, but she had a plan to actually develop such a health monitoring system. And for now, there's no apparent you know, move in this direction. So I think without this, we'll be in trouble. Now, all the aspect of the what I'm calling participating and democratic approaches of public health, I think we've done some progress, and we should be better prepared the next time because there is now experiences, research, we've published them, people can have access to them. And there are also some new health monitoring system, which I don't know yet how precise it is, but there's a lot of work being done, which is wastewater surveillance, which has been very successful, and a lot of health departments now have experience with it. So this may help us a little. And otherwise, the key health monitoring aspect is still not there. And this is foundational for public health.
Other questions?
Thank you so much. I'm Teresa Osipuk. I'm a social epidemiologist, and I'm really interested in your view of population health and how interdisciplinary work and
That's me. That's me. I should
Stay over
not-
there.
I should-
And how intersectoral work comes into play for population health.
Okay.
Can you comment on that?
Yeah.
Where it's going and in your view from the editor of AJPH and a leader in the field?
Okay, thank you very much. This is something I didn't cover, and so your question is just very welcome. And I think for the policy aspect, community engagement is something that is being developed. Many health departments, especially, for example, in Boston with Bisola, Chikutu, etc., have developed it, and so there is experience. Now, on the research side, you can also have participatory and epidemiology, which involve the community. It's a little bit more than methods, those theories like intersectionality is more like a philosophy, because you are going to do your research, but at the same time, the having an active participation of the community in which you're intervening, and you're going to change the situation in the community while you do your research. So it's an approach that is complex, but extremely interesting, and there is a lot of research that has been done. There's a lot of experience. Our editor, Lisa Bauleg, is someone who has lots of experience and teaches it, etc. And so we've been trying to develop that in the journal as one of our main sector. So there is we are used epidemiologists to be working and running our studies from our office and going and giving instruction in the community. Well, at some point, what is needed is to go to the community, understand what are their needs and how they see how research can be implemented. And in the research process, try to change the community so that we are visualizing the impact of our research as we do it. So these are things you cannot understand in 1 minute. These are things that take time. It took me a lot of time to understand it because it's more like a philosophy. You work on it, then you apply it in your own research, then you start to understand. But I think that's the domain.
So you think, so if I'm hearing you right, you're thinking about population health and interdisciplinary, intersectoral as through community engagement and people's interplay with research through community engagement in their own lives as engaging with, and that's the way that that's the way you see population health connecting through community engagement?
Yeah, it doesn't need to be the only way,
Okay.
but I think this is a trend now. I mean,
Okay.
and many, you need to be young and very creative to go into this type of research because it's kind of takes you body and soul, as Henry would say. And
Yeah.
but yes,
Okay,
yes.
thank
and-
you.
Hi, I'm David Jacobs. I
didn't.
thank you. I wonder about what you think about population size, which, in the 17 or 1800s, when people were saying that if we ever got up to 1 billion people, that would be death to everybody. Now we're at 8 billion going to 9 billion. And it seems as though everything is easier. Immigration, for example, if you get fewer people, we'd be happier, it'd be a little bigger. But the economy falls apart. Look what's happening in China, and all of a sudden they're encouraging more births. I wonder what you have a solution for this issue, and how does it interplay with all these other great ideas?
Yeah, because I'm stepping down from the journal and becoming UN president director, so no, but that's a very good question, David. And David and I have interacted a lot over time about articles and reviews and others. So I'm very happy to senior here. And so my experience, on my perspective is really a historical perspective. Because I always, when I have those type of questions, I wonder, what happened in the past, etc. And what I notice is that each time there were these types of threats, and there've been again and again threats of overpopulation. I don't know if you remember, but in the early 19th century, there was this economist called Malthus. And just on the basis of number, and he had simulated growth of population as being exponential and growth of food production as being linear. So you had food production and you had growth of population, and there was, implosion of the planet because of lack of food. Never happened. People ask, we have ever more complex data for the analysis compared to what we had before. Are we able to analyze this complex data? I never saw technical issues as being unresolved historically. I always found that all those issues have been resolved. The production of food has been resolved in the 19th century. The analysis of complex data have been resolved all along the way. The problem is not technical. The problem is social and political. That's where the whole question is. Are we going to get the right government to approach these questions and solve them because we can solve them? Or are we going to have the wrong government and the wrong social structures and maybe going against the wall? So I think that's the problem. It's not so much the complexity, but more, the means that we give to ourselves to solve those questions.
I'm Catherine Harrison. I'm a friend of SPH. I work in emergency response across the river, and I also am the state lead for Healthy Democracy, Healthy People. And I think just what you just said at the end there is like, so at the same time that we might see one administration or one political party or whatever affecting scientific, social, political, and technical conditions for health, we also see, though, differences in impacts to the pathways of people to have power over those future decisions, right? So I think access to voting is something that would be great to hear more about in this conversation, because although voting is not the only form of civic demonstration of power, it is the one most readily accessible to us as individuals, and so I think the concern, like, if you could say more in terms of like research, and we've seen a little, especially with the rolling back of the voting rights, the VRA, in terms of the impacts of that on health. And then like through these pathways of the levers, because that is where it feels like getting, at least in the conversations I've had of like connecting folks, these dots to then like why your vote matters and why we still have such low voter turnout, even among healthcare professionals who vote at rates 12 to 23% lower than the general population. It's like, okay, so then what? Because then all of these things could happen and go in one direction with one administration or the other, while at the same time, the lever for future change is also being eroded. So I don't know, that was just striking me as I was listening, wondering if you have any reflections.
All right,
on
we're
that.
at the top of the hour. Why don't we let Dr. Moravia give a quick response to that, and then
Sorry,
we'll
yeah.
wrap up.
It's a great, absolutely very important question, and also because it's the limits of, what I was able to show.
Yeah.
I mean, there is republished work that shows that the Civil Rights Act had the impact on the health of African American. And the main reason behind all this is that when you have a place at the table where the decisions are taken, things are going better. If you're not represented or you cannot have your voice, included, then things cannot go in the direction that you would like them to go the way, So I think also, very importantly, I don't think that one administration, if we have a Harris administration, it will solve all the problem. I don't think so. I think it will put us in better conditions to solve the real problem is how democratic are we? How participatory are we? And create this because without the interaction between, public health professional and politician, and the policy makers, you cannot have trust. And at some point, people think, it's just nuts under my control. But trust is created by close contact, connection, respect. And we need to build that. And community engagement is a great term. It should stay with us, and we should use it as much as possible in one condition or the other. So.
Great, thanks everyone. Unfortunately, that's all we have time for. Students and postdocs, please stick around for the workshop that's happening with Dr. Marabia at 11:30 to talk about publishing in AJPH and tips for abstracts. Please join me in thanking Dr. Marabia. We will be rearranging the room prior to the workshop, so if you want to chat, please hang out in the hallway commons. Thank you.